Welcome back to the deep dive. Today we are taking a really fascinating turn. We're moving past the general overview of heart failure, or HF, and we're going to zero in on the specific physical signs.
hmm
And these aren't just, dry clinical facts. These are the deeply instructive, almost telltale cues that clinicians rely on.
Exactly.
The specific sounds, the pressures, and sometimes these really paradoxical appearances that paint a detailed picture of what's truly happening inside the body. So our mission today for you is to get a genuine shortcut to clinical fluency. We're going to distill the most powerful and often surprising physical indicators from this source material.
It's such an essential exercise because, the physical exam in heart failure
Hmm.
it's a masterclass in nuance.
Right.
It reveals a whole spectrum of pathology. We're looking for everything from really subtle changes in a patient's general appearance to specific measurable pressures in their circulation and even distinct sounds when we listen to their heart.
So the exam is like a monitor in a way.
Think of it as the most immediate, real-time hemodynamic monitor that we have.
Okay, so let's start with that first look, the immediate visual assessment. Our sources note that a lot of patients in the mild to moderate stages of HF can actually appear quite comfortable.
They can. Sitting still, they might look perfectly fine.
You wouldn't suspect a thing.
Not until you ask them to move.
Mhm.
That's where you see it. The first sign of early failure is often functional. It's dyspnea on minimal exertion.
So just walking across the room.
Just walking across the room or getting dressed, they look fine at rest, but their cardiac reserve it's exhausted almost instantly.
But then when the disease becomes severe, that visual presentation, it shifts dramatically. We're talking about patients who might have to sit bolt upright just to breathe.
Precisely. They appear anxious, maybe diaphoretic sweaty, and they're dyspneic even at rest.
Yeah.
And then we start seeing immediate signs of trouble with circulation.
Like what?
Well, pallor, which can be related to low output or maybe an associated emia,
Oh,
or even a dusky sort of bluish appearance if the cardiac output is really impaired. You look for cool extremities, peripheral cyanosis,
the classic sign.
classic markers that the body is shunting blood, prioritizing the core organs over the periphery.
Okay, here's a concept that I found truly surprising, and it really illustrates how systemic this condition is. Cardiac cachexia.
Hmm.
I think for many people, weight loss suggests, cancer or maybe starvation. But in heart failure, it points to profound chronic severity.
Cachexia is defined very specifically. It's unintentional edema-free weight loss of more than 5% of body weight over 12 months.
And what does that look like?
The physical manifestation it's heartbreakingly specific. You see bitemporal wasting in the temples and muscle loss, predominantly in the upper body.
So why does the body essentially waste away when the main issue is a failing pump? The sources say it's much more than just not eating enough. What's the fundamental driver here?
It's a multi-layered catabolic storm. Yes, poor oral intake, anorexia, and poor nutrient absorption because of edema in the bowel wall. Those contribute.
Sure.
But the key driver is internal inflammation. Heart failure isn't just a plumbing problem. It's an inflammatory disease state.
Okay.
The chronically stressed heart and the congested organs, they release these inflammatory cytokines, like TNF-alpha, which fundamentally shift the body into a catabolic or breakdown state.
Oh.
So this systemic inflammation just overrides the normal anabolic or building systems, like the growth hormone pathway. The body is essentially consuming itself. It turns the patient's system into this constant furnace where muscle is being broken down faster than it can be built, no matter the calorie intake.
That completely reframes the condition. So if cachexia shows us this chronic inflammatory state, the vital signs, I assume, show us the immediate mechanical response. How do the numbers shift?
Well, in the initial sort of new onset phases of failure, the sympathetic nervous system tries desperately to compensate.
To fight or flight.
Exactly. So we often see the heart rate speed up and the blood pressure might actually increase initially. That reflects this intense effort to keep volume moving.
But that can't last.
It can't last forever.
What?
No. When that compensation fails in severe chronic failure, the picture completely flips. We see frank hypotension, often a rapid, thready pulse, and a really critical feature, a narrow pulse pressure.
And what does that mean, a narrow pulse pressure?
That small difference between the systolic and diastolic pressure, it's a direct sign of severely depressed cardiac output.
Speaking of pulses, let's discuss one of the most specific, almost alarming signs, pulsus alternans. I've heard this described as a finding that immediately raises a huge red flag.
Yes, it's not common, but when you find it, it means the patient is in severe straits. Pulsus alternans is this striking physical sign of alternatingly strong and weak
So
pulse.
you can actually feel it.
Oh yeah, when you're palpating the peripheral pulse, you literally feel the intensity change beat by beat. Strong beat, weak beat, strong beat, weak beat.
What's happening inside to cause that?
It points directly to a severe reduction in left ventricular contractility. The heart muscle is so fatigued that it can't fully recover between beats. So on one cycle, it pumps a larger volume. That's your strong beat.
Okay.
But the next cycle, because of incomplete recovery or maybe inadequate filling, the stroke volume is much smaller. That's the weak beat. It's a classic sign of a severely depressed left ventricle.
Before we move on, we have to touch on breathing. Not just shortness of breath, but the rhythm itself. The rate might be fine seated, but then it increases as soon as you lie down.
Right, orthopnea. And then in advanced failure, you can get these really dramatic periodic patterns.
Then that would be too long.
Stokes respirations. This is a crucial sign of advanced HF, low cardiac output affecting the brain's respiratory control center. It's a cycle. Periods of deep, rapid breathing, then gradually shallower breathing, and then a period of apnea. Complete cessation.
And the patient knows this is happening.
Usually not. What often alarms the family is that these cycles happen at night, during sleep. The patient is completely unaware. The family just describes it as, the patient stopping breathing or gasping in the night. It's a frightening sign.
All right, so from the heart's response, let's look at the backup, the fluid backup. We're focusing now on the neck, specifically the jugular venous pulse, or JVP. This isn't just a vein. It's a clinical proxy, right?
It's a proxy for estimating the right atrial pressure. Yeah.
The sources outline how to assess this, positioning the patient at 45 degrees. But let's forget the math for a second. Conceptually, what is a high JVP telling us right away?
It's giving us a real-time window into the central volume status and the heart's ability to handle that volume. If the pressure in the right atrium is high, it backs up into the large veins, the jugulars.
And you can see it.
You can see it. Normally it's low, maybe a few centimeters above the sternal angle. If it's high, rising up toward the angle of the jaw, it means the heart cannot effectively accept or pump out the blood that's returning to it.
But it can be tricky.
It can be. In mild heart failure, the JVP might look deceptively normal at rest. The body's still compensating. But we can unmask that failure with certain maneuvers.
And this brings us to things like the hepatojugular reflex and the abdominojugular test. Why are we pushing on the liver or the abdomen here?
What we're doing is essentially challenging the right heart. When you apply firm, continuous pressure over the liver or the mid-abdomen for, say, 15 to 30 seconds, you're squeezing pooled venous blood out of the abdominal organ.
You're forcing it back into the system.
You're forcing it back into the vena cava and the right atrium. It's a temporary flood.
And a healthy heart can handle that.
Instantly. In a healthy person, the JVP might briefly rise, but it falls right back down. In a patient with HF, the right ventricle can't manage that extra volume. The pressure stays high, and the JVP stays elevated for as long as you press. It's a hugely sensitive sign of volume overload.
Okay, this raises a question about prognosis. There's another sign called Kussmaul's sign. This isn't just a high JVP, it's a paradoxical movement.
It is the ultimate paradox in venous pressure. Normally, when you take a deep breath in, the pressure inside your chest drops, which helps suck blood into the heart. The JVP falls.
Right.
Kussmaul's sign is the exact opposite. The JVP rises with inspiration.
Which is alarming. What does that imply?
It implies the heart is severely restricted, often by advanced biventricular HF. It's a classic marker of severe disease because it shows the volume can't be accommodated, even when the chest is trying to help pull it in. Clinically, it's a sign of a very poor outcome.
And visually, if you're looking at the neck and there's severe right HF, maybe with significant tricuspid regurgitation, you might actually see something in the rhythm of the pulse itself.
Yes, you would. The classic jugular venous waveform would show prominent V waves. With tricuspid regurgitation, when the right ventricle contracts, blood shoots backward through that leaky valve into the right atrium. That causes a massive surge of pressure, the V wave. It's a literal visual confirmation of that backflow.
Okay, so moving from pressure to sound. Let's start with the lungs. We've established fluid is backing up, so the classic expectation is to hear rails or crackles.
That's right. Rails are from fluid leaking from the capillaries into the lung tissue and eventually into the alveoli, the air sacs. You hear them at the lung bases, usually.
But there's a crucial diagnostic trap here that the sources really emphasize. That same congestion, the fluid in the tissue around the bronchi, can cause wheezing. And if a clinician only hears wheezing, they might misdiagnose it as asthma or COPD.
And give the completely wrong treatment. Bronchodilators aren't going to help fluid overload. That differential is paramount. But here's the paradox we really need to focus on. One of the most surprising findings in chronic HF,
Which is?
rails may be completely absent, even if the patient has long-standing severe pulmonary venous hypertension.
That seems wrong. If the pressures are high, shouldn't the lungs sound wet? Why would the crackles disappear?
It's an extraordinary example of biological adaptation. In patients with elevated pulmonary pressures for months or years, their lymphatic drainage system in the lungs actually hypertrophies. It gets bigger and stronger.
So it gets better at its job.
It becomes highly efficient. It works so hard draining fluid out of the interstitial space that it prevents it from spilling over into the alveoli, which is what causes that crackling sound. So a quiet lung in a chronic HF patient can be just as dangerous as a wet lung.
That is fascinating. The body compensating over years. Okay, shifting to the heart itself, to palpation. In chronic HF, the heart physically changes shape, doesn't it?
It undergoes ventricular remodeling. In a healthy heart, the apical impulse is small and localized. In dilated cardiomyopathy, the impulse is displaced downward and to the left, and it often feels diffuse because the left ventricle is so large and overworked.
And what about the right side?
If you have severe right-sided HF, you can sometimes palpate right ventricular heave or peristernal lift right along the left sternal border. That tells you the right side of the heart is physically laboring so hard, it's pushing against the chest wall.
Let's move to the most famous sounds, the gallop rhythms. The sound that instantly suggests severe compromise is the S3 gallop.
The S3, often described as a ventricular gallop, you can remember the rhythm Kentucky, is usually heard with volume overload and tachycardia.
Why does it happen?
It occurs when blood rushes into a torally compliant volume overloaded ventricle during rapid filling. It has very negative prognostic significance. When you hear an S3, you know that heart is struggling desperately to manage incoming volume.
And what about the S4 gallop?
The S4, or atrial gallop tendency, is less specific for failure, but it's very common in one subtype. HF with preserved ejection fraction, or HFpEF.
Okay.
This sound is from the atrium contracting as the stiff, non-compliant ventricle, often due to long-standing hypertension. So S3 is a volume problem. S4 is a stiffness problem.
Finally, murmurs. We often think of murmurs as valve diseases, but in advanced HF, the sources say we often hear murmurs of mitral and tricuspid regurgitation.
And that's a crucial point. These are often functional murmurs, not structural problems with the valve itself.
What does that mean?
When the heart chambers dilate from the volume overload, it literally pulls the valve leaflets apart. The annulus, the ring holding the valve, gets stretched so the leaflets can't close properly. The valve itself is fine, but the structure holding it is failing.
So now we trace that congestion down into the lower half of the body, starting with the abdomen. An enlarged liver, hepatomegaly, is an early sign.
A very early sign of volume backup.
And initially, that liver is often tender. Why the tenderness?
It's because the capsule surrounding the liver is being stretched rapidly by the sudden backup of venous blood. That tenderness is a sign of acute congestion. Interestingly, in chronic HF, the tenderness can disappear even if the liver stays large.
And if there's severe tricuspid regurgitation, you might even feel a pulsatile liver edge. That's the blood surging backward into the liver with every beat.
That's exactly what it is.
And the long-term devastating consequence of this is cardiac cirrhosis.
Yes. If the congestion is sustained long enough, it leads to fibrosis, scarring of the liver tissue resulting in cardiac cirrhosis, and often congestive splenomegaly. We also start to see mild to moderate ascites fluid in the abdominal cavity.
But the source material is quick to differentiate this. Massive ascites should make you think of other causes.
Absolutely. While HF can cause ascites, if it's truly massive, a clinician has to investigate other possibilities, like primary liver failure or maybe constrictive pericarditis, which cause extreme systemic congestion. The degree matters.
And finally, we get to the most visible sign for the patient and their family, edema, the swelling.
In chronic HF, this edema is classic. It's dependent, it follows gravity, so feet, ankles, the sacrum if the patient is bedridden, and it's symmetric and pitting.
Pitting is the key feature.
It's a key feature. You press the skin, and an indentation remains for several seconds.
And if it's really chronic and severe, the changes go beyond just swelling.
Oh, yes. You get massive, uncontrolled fluid that causes skin reddening, hardening, or induration. Eventually, it can become weeping, and that significantly raises the risk of skin infections like cellulitis.
And the most severe form is called?
Anasarca. Massive, generalized edema involving the legs, the sacrum, the abdominal wall, everything.
But this leads to some really critical differentiators,
Yeah,
because not all swelling is heart failure.
exactly. First, remember that paradox.
Hmm?
Edema can be completely absent in acute HF or in very young adults, even with marked venous hypertension.
Hmm.
No ankle swelling doesn't rule out failure.
Yeah.
Second, if the edema is strictly on one side, unilateral, it's usually local issue, a DVT, trauma, something like that.
Right.
And third, if the swelling is non-pitting and doesn't respond to diuretics, that strongly suggests lymphedema, which is a whole different workup. The physical exam is about synthesis, but it's also about exclusion.
We've really navigated a complex multi-system map of disease severity in this deep dive. We've gone from the subtle metabolic warfare of cardiac cachexia to the alarming rhythm of pulsus alternans, and through that paradox of the silent lung.
The synthesis here is profound, isn't it?
Mm-hmm.
The physical exam, even without any advanced technology, gives you immediate, powerful diagnostic and prognostic data. We've seen that HF impacts everything: nutrition, circulation, inflammation, the mechanics of the vessels. The body is telling a complete story of failure and compensation.
And that leads to our final thought for you. The signs we discussed, an S3 gallop, a high JVP, that non-structural valve leak, these don't just confirm a diagnosis, they fundamentally drive immediate therapeutic decisions. So given the risk of misdiagnosis, especially confusing that congestion-induced wheezing with COPD, how might recognizing these specific physical patterns fundamentally change the timeline for intervention? It reminds us that just listening and looking are still the most powerful diagnostics in the clinician's toolkit.